Okay, good morning, everyone. Welcome to the UCT Africa morning meetings. Today we'll be having a presentation done by one of the colleagues, one of the registrars elsewhere, Dr. Vorster. So, Jaco, do you mind taking over your presentation?
Okay, yes. I'm Dr. Vorster, one of the registrars in ENT at the University of Cape Town, and I'll be presenting on Lemierre syndrome this morning. So I'll start with a patient presentation. So my disclaimer, all my content is referenced and then consent was obtained from the patient's parents. Presenting a pediatric patient, an 18-month-old girl, previously healthy with no known comorbidities, not immunocompromised to our knowledge, and she received all the immunizations up to date by the time she presented. She presented with a background history of an upper respiratory tract infection, followed by a 3-day history of persistent fever, and then a 3-day history of a progressive neck swelling that was thought to be a left submandibular abscess. But she also had diarrhea and dehydration on presentation to Red Cross Hospital. This is what the patient's abscess looked like clinically, pre-operatively on assessment. And you can see she's got quite an extensive swelling on the left angle of mandible, extending quite posteriorly. Because of a concern of possible deep space neck involvement, a CT scan was ordered for her. And this showed her to have left parotid space involvement, left parapharyngeal space involvement, left carotid space involvement, extending all the way to the prevertebral space and involvement of a superior mediastinum of a collection. And then also it was found that she had a left internal jugular vein thrombosis, which was quite extensive on that scan. This is just a few images of a scan where one can see that abscess going into the left carotid space. One can clearly see the carotid artery filling up with contrast on the left, but you can't see the left internal jugular vein on the left side. And this is just showing the collection going down all the way to the mediastinum. Also looks like the collection deviates the trachea. And then on the coronal image, you can also see that it's quite an extensive abscess. This patient was started on IV augmentin prior to transfer to Red Cross Hospital. Once she arrived here, drainage was done in theatre through a cervical approach as well as a transoral approach. Patient was then transferred to ICU on mechanical ventilation post-surgery because one of the big reasons was they saw quite a bit of supraglottic edema on intubation. Day 2 post-operatively, Clexane was added to the patient's regimen because of the internal jugular vein thrombosis. Patient did well in ICU, not on inotropic support. She was extubated on day 3 post-operatively, and during her ICU stay, there was no evidence of septic embolization to the lungs or the brain. On microbiology, this patient they isolated a Staphylococcus aureus, a sensitive one, from the pus swabs done. No Fusobacterium necrophorum was isolated. The Staphylococcus aureus was also not isolated on blood cultures. She had a normal echo done in the first post-operative week, and this was just to make sure that there's no concurrent right endocarditis. Once the microbiology results was out, the patient was switched to IV cloxacillin as directed therapy, and this was given intravenously for 2 weeks post-surgery. Patient was discharged on a prolonged course of oral flucloxacin. So at the 2-week interval, we consulted hematology as we wanted some guidance on how long to continue the anticoagulation for the thrombosed left internal jugular vein. And then we decided to do an ultrasound to see if a thrombus is resolving or if it's still there. And on this 2 ultrasound images, one can see a the patent left common carotid artery, and then quite extensive clot or thrombus sitting in the left internal jugular vein. So for anticoagulation management, we consulted the hematologist post the ultrasound, and then a decision was made to continue the patient on prolonged anticoagulation, which was done with Clexane or enoxaparin, and this was based on the ultrasound findings as well as its institutional preference guided by the South African pediatric anticoagulation guidelines. So outcome for this patient, she had a mostly uneventful in-hospital course. She was discharged on about week 3 post-surgery. Didn't require any relux surgeries. The patient was seen week 4 post-surgery in the clinic, doing well, taking full oral feeds, and there was no evidence of septic metastases, and overall a good outcome for this patient. So just looking at the literature, one of our big questions was regarding anticoagulation management in these patients with Lemierre syndrome. And so Lemierre syndrome was previously described, but the term was first coined by Dr. Lemierre, a French microbiologist, when he described 20 cases of Lemierre syndrome in 1936. At the time, there was a 90% mortality rate in the pre-antibiotic era if you were diagnosed with Lemierre syndrome. So the formal definition of Lemierre syndrome is oropharyngeal infection, typically as pharyngitis or tonsillitis, that then follows a bacteremia with very typically Fusobacterium necrophorum, which is an anaerobic organism, which then leads to septic internal jugular vein thrombosis. And some articles then also feel that evidence of septic metastases is necessary for the diagnosis, but others feel that septic metastases is not necessary for the diagnosis. And septic metastases can also be used as a marker of jugular vein thrombosis, where you don't see it, but you do see evidence of septic metastases. And then there's other people that feel like that there should be coined Lemierre's-like syndromes, and this is any syndrome where you've got a non-oropharyngeal primary, like infections coming from the middle ear, sinonasal infections, that's associated with internal jugular vein thrombosis. And they also feel that any causative organism other than the Fusobacterium or anaerobes then should also be coined rather a Lemierre's-like syndrome. So our patient would most likely be classified then as a Lemierre's-like syndrome. Epidemiology, this predominantly happens in previously healthy patients, that's immunocompetent with no other comorbidities. More than 70% of the cases happens in adolescents from 16 to 25 years old, although it's been described in patients of 80 years old. The youngest patient described was 5 weeks old. It's a relatively rare disease with 0.6 to 2.3 cases per million population. And then there's a recent increase in cases in the last decade seen, and this is postulated to be due to arising new resistance patterns, as well as change in antibiotic prescribing patterns. Looking at the pathogenesis, it usually starts with a primary infection, typically an oropharyngeal infection, then with lymphatic spread, and via the lymphatic spread there is a bacteremia leading to phlebitis of the internal jugular vein, and then after that, formation of thrombosis. Because of the location of the thrombosis in the blood space, but often can have involvement of the lower cranial nerves as well, and infection can spread up to involve the base of skull meninges with brain infarcts as well. So continuing on pathogenesis, it's usually a virulent strain of of a microbe that induce platelet aggregation. And this is mediated by lipopolysaccharide endotoxins, and these irritate the intima of the internal jugular vein, leading to thrombosis. It's also postulated that there's multiplication of organisms in the thrombus, and this multiplication of microbes in the thrombus results in fragmentation and then eventually embolization of the septic emboli. So just looking at the sources as primary infection, the pharynx is involved in 32% of cases, and the middle ear is involved in 18% of cases. So majority of patients will have a pharyngeal infection leading up to Lemierre syndrome. I mean, there's this big group of 36% that's termed as other. I mean, typical other causes that's been reported in literature is trauma-related, post-dental extractions, after mumps infections, and Epstein-Barr virus infections. Microbiology, typically it's the Fusobacterium necrophorum that causes the infection, but other bugs have also been isolated, like Staphylococcus aureus, Streptococcus, Eikenella, Bacteroides, Candida. Clinically, see this typically, very typical presentation is a severe tonsillitis or a severe pharyngitis without abscess formation. And patients typically get better after the tonsillitis or pharyngitis and then present with a grumbling fever and just not getting completely better, and then present 4 weeks later with evidence of septic emboli to the lungs or the brains, typically present with either seizures or lung abscesses, and then found to have a septic focus sitting in the internal jugular vein. So just one of the warning signs is ongoing fever despite antibiotics after oropharyngeal infection, associated with unilateral neck pain. The oropharyngeal infection might clear up completely before the progression of disease. And then another common source, or not a common source, but another potential source is cutaneous infection, like infected herpes ulcer. So one of the big studies that looked at a large group of patients reported that the 3 most common symptoms in pediatric patients are fever at 73.5%, a sore throat in 47.9%, and then neck pain and stiffness in 28.6%. If you've got associated torticollis, Horner syndrome, or lower cranial nerve palsy, that should raise or that should urge you to look further for possible Lemierre syndrome. Looking at septic emboli, majority, about 53%, will be pulmonary septic emboli, and then thrombus propagation of CNS involvement is seen in about 20%, and then about 17% of patients do have spread to the bone, and then other sites make up only 10%. Looking at imaging, contrasted CT scan is the gold standard and more sensitive than ultrasound for picking up internal jugular vein thrombosis. But ultrasound does have good sensitivity for picking up internal jugular vein thrombosis, especially color flow Doppler. The drawbacks of ultrasound is that you can't visualize the internal jugular vein completely below the clavicle or the mandible. It is important to note that when you do initial imaging in a patient presenting, but the thrombus might not be apparent on your initial imaging, and the patient continues to progress, and your suspicion is quite high later on, but the patient might have a Lemierre syndrome. Repeat imaging will be necessary to see if there's a clot in the internal jugular vein. Management, it's predominantly a multidisciplinary team management. These patients are quite sick usually when they come in. Early broad spectrum antibiotics, early source control, organ support as needed in an ICU, And then exclusion and monitoring for septic metastases is important. And then anticoagulation is a controversial topic, which we'll look at just now. In terms of antimicrobials, research does suggest that one start with a penicillin, but cover beta-lactamase producing strains, as well as anaerobic cover. So in our setting, we use amoxicillin clavulanic acid, known as Augmentin, and that's very appropriate first-line management. Literature also suggests that clindamycin is very good and sufficient as monotherapy for these patients if you can't use Augmentin. And then there's a strong recommendation that you give 2 weeks of intravenous antibiotics, as there is still microbes in the thrombus, and that this still continues to embolize after the infection has been cleared clinically. And then there's also a strong recommendation to continue antimicrobials for 6 weeks after the diagnosis, and the remainder of the cover can usually be done with oral therapy. So anticoagulation in these patients, like I said, is controversial, and it's mostly based on institutional preference rather than guided by research. Usually, in most centers, they'll consult a hematologist. In most of the cases, in pediatric patients, there's a preference for low molecular weight heparin, like enoxaparin or clexane, and to avoid warfarin and other anticoagulants. In our institution, they use a pediatric anticoagulation guidelines, which I'll just share a slide on just now. But then it's also to note that should the choice be to start anticoagulation, there's no consensus on the duration of treatment. There is, in the literature, many centers that defer anticoagulation when there's a good initial response to antibiotics, uncomplicated hospitalization, and then no evidence of septic emboli. So some centers would choose not to anticoagulate these patients. So the South African pediatric anticoagulation guidelines gives a recommendation, and this is a broad recommendation for venous thromboembolisms in pediatric patients. They advise enoxaparin at 1 milligram per kilogram per dose. And then, because steady state in children is more difficult to achieve in adults, they strongly recommend therapeutic monitoring with anti-factor 10A levels with a target range of 0.5 to 1 as a target range. Since these are considered as provoked venous thromboembolisms rather than idiopathic, they recommend, it's a typo here, they recommend 3 months of anticoagulation in total. And they also recommend monitoring with imaging both during and after completion of anticoagulation. So in general, the current prognosis of Lemierre syndrome has a mortality rate of 4 to 18%, and the earlier the detection, the better the outcome for these patients. Looking at pediatric patients, the youngest patient is a 5-week-old that's prescribed in the literature. Specifically in infants, Staphylococcus aureus is a very important causative organism to remember. And then neck mass or swelling only happens in 6% of cases. So the absence of a neck mass or swelling should not make one exclude a Lemierre syndrome in patients you otherwise have a high index of suspicion for. When just looking at deep neck space infections and Lemierre syndrome, this is a study that involved both adults and children. In 2022, it was a retrospective review of 592 cases. And Lemierre, in the setting of deep neck space infection, you've got a CRP of more than 200. There should be a strong consideration for Lemierre syndrome. If you've got involvement of 3 or more spaces, you should also have a strong, high suspicion for Lemierre syndrome. Involvement of a carotid space has a very high predictive value for Lemierre syndrome with a p-value of less than 0.001. And then if you isolate Fusobacterium necrophorum, you should also actively look for Lemierre syndrome with a p-value of less than 0.001 in this population. And then carotid, look at carotid space involvement along with a CRP of more than 100, your odds ratio is 94 for having a Lemierre syndrome. So these are my references for presentation, and that's the end.
Thanks, Jaco. That's a very nice presentation. Matt,
no, I mean, as I said, it's a very nice presentation. I feel like we're seeing more of this. What do you think? I also don't know if it's because we have a higher index of suspicion and we have to be asking our radiologists in our first forms. I don't know what you think, Bob.
yeah, the only word of caution is that I know there were studies in the 90s when I was in Pittsburgh where they were looking at the thrombosis rate of internal jugular veins after necrosis. And they reported quite a high rate, but then that doesn't correlate with the TAP success rates that you find with TAP conjugates. So I think one should just be cautious that, especially ultrasound, you might have an overcall in terms of internal jugular vein diffusion. So I've got just that word of caution. But clearly these are patients that are high risk. Did you come across anything about ligating the internal jugular vein?
Jaco?
Sorry, Prof, would you mind just repeating the question?
Have you come across anything about ligating the internal jugular vein in patients who are shooting of emboli?
Yes, so when you've got a patient this started on anticoagulation and they continue to shoot off septic emboli and you just can't control it, they do recommend internal jugular vein ligation. But the cases that need it, the chance of needing that is extremely rare.
Okay.
Yeah, so it's a very rare occurrence, but they do still talk about it in the literature for resistant cases.
Okay, yeah, because when I trained many years ago, and my professor probably trained almost in the pre-antibiotic era, but certainly it was more commonly done. But as you point out, now that we've got more manageable and safe anticoagulation, I'm sure that's been supplanted by medical therapy. Do you say any comments? Anybody else?
That's very nice. Well done, Jaco. Very nice.
Okay, I don't see any questions on the chat platform.
I just wanted to add something. Yeah. So I just wanted to add something because this was our patient. I think that was really good. Thanks, Jaco. My big issue was when we first had this child was if you have someone who has a jugular vein thrombosis and you need to probably go back to get infection control, because a lot of these kids actually have mediastinal extension or have recurrence. And so how long do we need to keep the clexane for? And do we stop and start and stop and start? The one thing that is clear in the literature is that there is no guideline because it's so rare. But what we noticed with local practice was they have a low threshold to just keep the child on clexane. So for 6 weeks, and they train the mother and everything. So I think that was something that I was actually quite impressed with at Red Cross, that they have a low threshold to keep someone on clexane. And this mom, for example, is from Mitchell's Plain. She gets her injectables, all her consumables and everything, and she actually does it at home for 6 weeks. So that was very impressive for me. I was under the impression that, oh, the kids stay in the hospital, we monitor them. It can be actually well instituted. And the reason why that was the first thing that I was impressed with. The second thing is you have to keep them on antibiotic therapy for longer than we think, because as the clot breaks down, that can embolize, but it can also have microbiomes in that clot. And so that was something that was also important to note. So the longer therapy for antibiotics was also important. I think those two things I took home from this, which is probably, it changes our practice a little bit more. We keep them in for longer, we watch them for longer, we scan them, you know, with serial scans and all of that, just to make sure that we're not causing, you know, ongoing infection complications. So that was why I thought it was nice to look at this case in point, because we see a lot of deep neck space infections, but none of them in the last 4 or 5 years, especially with Charles's MMed, none of them had thrombosis, and all of them had dropped their immunization schedules. So all our kids did not fulfill their immunization schedules. This one as well, she'd missed her immunization by 2 months. So that's why we're seeing these deep neck space infections. But this was the first one with the thrombus in our 4 or 5 years. So thanks, Jaco.
Right, thank you very much. If there are no more questions, I think we'll end the meeting there. I don't see any more questions. All right, I think we'll end the meeting there. Thank you very much for your time. We'll see you on Friday again for our next meeting. Okay.
Thanks very much. Thank you.